now as we get into our respiratory medications, we talk a lot about those in our airway chapter, but we want to touch on them again here. So as we're taking care of our patients that are having having trouble breathing, our patients that have an inhaler, or they're on their pseudoephedrine, they're on antihistamine for their Benadryl, their antihistamine, their antitussive, their decongestants. So we typically think about what we're going to give as our beta-2 receptors, which produces our bronchodilation and vasodilation. It's the most beneficial for our patients in respiratory distress. So we give our albuterol, Atrovent, it can increase that heart rate, but if I have to weigh out, do I want to increase their heart rate from 120 to 140 by giving the albuterol and they can breathe? Yes, I'll take it, because it'll come right back down. And a lot of times you'll actually see it go down instead of go up. But I at least want to try to decrease that oxygen demand on the myocardium if I can. The second line treatment in the respiratory emergency is xanthines. The class of drugs relieves airway constriction by relaxing the smooth muscle in the bronchioles and stimulating cardiac muscle to work harder, thereby increasing blood flow. These drugs also stimulate the central nervous system. One notable xanthine is caffeine, the well-known central nervous system stimulant. Other respiratory medications suppress the inflammatory response that typically causes acute distress for patients with restrictive airway disease. In the acute care setting, corticosteroids, including methylprednisolone, Solumedrol, and Decadron, can be administered for this purpose. So it just depends on what you're carrying. I think most of us carry Solumedrol. So whatever that next line is. Up to, now remember, if your patient's not responding, I can take this all the way through to anaphylaxis of, let me give this patient some epinephrine.